Hi everyone. We shall continue with next topic on what you can see in this video is about the eye is shaking involuntarily on both eyes, on this particular patient. So this involuntary movement of the eye is known to be the nystagmus. So nystagmus is one of the common symptoms that patient would have because of the ocular condition that they are having. Some patients, they're born with congenital nystagmus. Okay, so there are many factors that is actually contributing to this. Okay, so one of the common problem in this would be, wait, yeah, let me check if let's say the recording is going. Okay, so one of the common reason is, okay, if let's say a patient's fovea is not developed fully. So what will happen to this patient is when the fovea is not fully developed, okay, before I go to that, okay, how does this foveal development happens in a person? When an infant born, right, okay, the fovea is not fully developed. Okay, the fovea will develop until the plastic age is completed, about 9 years old. Okay, so it will slowly grow, to get the VA of 6.6. Okay, so emmetropization will happen in between. So that's a process of growing of the fovea. Okay, so so there are certain patients, they are born with cataract sometimes, or they're having some retinal related issues, ROPs. There are many things that can cause patient to have problem with their foveal development. Okay, so what's supposed to actually happen when an infant born, right? Okay, so they will start opening their eyes. When they start opening their eyes, light will go in into the eyes, and then the light will go in a straight line and fall on the retina area. So the more the images that an infant sees, that will actually lead to the development of the fovea. Okay, so the light that goes into the eye should fall on the fovea, not in front of the fovea or behind the fovea. So when a patient is having cataract, the light that goes in doesn't fall on the retina. Okay, it's being affected. So when the light is actually not falling on the retina, okay, on the fovea area, that fovea area is not being induced for the development. Okay, so that's what happened to the patient. If let's say patient has cataract, or if let's say the eye is having, the retina is having some problem or some any reason that caused them to not, the light that goes into the eye, the images that the patient sees, let's say it doesn't fall on the retina at the fovea area, the fovea will not specialize to become special. Okay, so what will happen is when light goes in, when they grow up, when light goes in, right, the fovea is not there, the specialized cells in the fovea are not there to actually absorb light at the foveal area so that the good clarity images being transferred to the brain. Okay, it is equal to the peripheral side also because the fovea is not fully developed. So what will happen is when the kid goes up, when kids grow up, right? What will happen is when light goes in, okay, the eye will be actually shaking, okay, to find out if let's say there is any area in that, in the macula part which has a highly specialized zone where the light can be absorbed and then send the details to brain or not. So that is the reason why like keep looking for the best fit, okay, to absorb the light or to make it fall on that particular specialized area which is not existing So the eye will be keep moving. Okay, so that is nystagmus. Okay, so this is OPT 3475, low vision and further optometric care. So the topic that will be covered in this video will be on nystagmus. Okay, so nystagmus is involuntary rhythmic oscillation of one or both eye. Okay, it can be monocular, it can be binocularly. Okay, and it is a sign of pathologic afferent visual pathway or disorder in oculomotor control. So there are many causes that leads to this problem. Okay, and as I mentioned, if let's say there is a cataract in the in the eye since young or born, okay, that also can lead to this. Or if let's say the patient is actually having some retinal related disease, that also could lead patient to have this nystagmus. So what are the factors that actually leads to this is the genetic disorder. Genetically, they have this problem, nystagmus problem. Development anomalies when the fovea is not fully developed, okay, during the growth also can affect this. Active pathology which can occur at any age. Okay, anything like if let's say a trauma, if let's say a patient is having a brain tumor at the age of 15, so anything that can occur at any age will also lead to this. Also, it's a contributing factor for a person to have nystagmus. So the prevalence is it affects about 1 over 5,000 to 10,000 persons. Okay, so this is the prevalence of nystagmus among the visually impaired person. So this is, it's not really rare, but it is there in the population. So you just need to be a bit observant to detect whether the patient is having nystagmus or not as a eye care practitioner. Okay, and the possible the possible symptoms that patient, so the image that is being transferred to the brain will be like multiple. When they are here, when they turn, okay, the turn, all the images will be transferred to the brain. So that might lead to dizziness for the patient. Vision related issue because the eye is keep shaking, the image won't be very clear for the patient. Okay, and needing to hold the head in a tilted or turned position. Okay, excuse me. So this patient would usually, they are not all the patient, but there are certain patients who actually have a head turn, okay, or they have to tilt their head to one side, okay, so that they can actually avoid the symptom. So they come in with head turn. Okay, that is one. Okay, another symptom is light sensitivity. So as I mentioned, this fovea has to fully grow so that they can actually absorb light. Now, since there is no particular zone in the retina that is actually, has specialized cells to absorb this excessive, to absorb this lights that goes into the eye. Okay, so when it goes in, right, there is no specific area where it will work like a sponge to absorb the light. So it goes on the retina, and then when it hit the retina area, can be any place, and then that light will be actually reflected, okay, scattered around in the eye, and that scattering of light in the eye will lead to patient to have light sensitivity or glare problem. Okay, if let's say the fovea is fully developed, when light goes in, most of the light will be absorbed by the fovea, so that more information can be transferred to the brain. But now, since there is no fovea area, it will be scattering around the eye. Next is trouble seeing when it is dark. Okay, so this is also another symptoms because the eye keep moving. Okay, so the absorption of the light in the dim area is going to be difficult because limited information is being absorbed by the eye. So that is also a trouble for the patient. And the sensation that the world is shaking will be there all the time, and it can be very annoying too for this patient. Okay, so these are the symptoms that patient would have if let's say they have nystagmus. Okay, in most cases, people develop nystagmus at a young age. Rarely, after the childhood days. The reason why is, okay, this is a developmental problem or ocular condition. Okay, but it doesn't mean that patient would not have nystagmus at a later stage. Okay, like for example, if let's say patient get a tumor or trauma at later stage of life, they could also develop nystagmus, but most cases, they develop at a young age. Okay, especially patient with, this foveal development problem, and also patient with albinism. Okay, so they can get it at a young age. So there are five primary types of nystagmus that we can see. Okay, number one is manifest, number two is latent, number two is manifest, latent, congenital, and acquired nystagmus. Okay, so we'll look at one by one. What are these types of nystagmus is all about? Okay, so with this manifest nystagmus, with this type, the symptoms are present at all times. You occlude eye, you don't occlude eye, all the time the symptoms are present. Okay, and the second one is latent nystagmus. With this type, the symptoms only occur when the person covers one of their eyes. Okay, when they look through both their eyes open, okay, they don't have any nystagmus. But when you actually occlude the eye, one of the eye, then they will have nystagmus. So this is latent. It is there, but only you need to trigger them to come out. The third one is manifest latent nystagmus. With this type, the symptoms are always there, but when the person covers one eye, the symptoms get worse. Okay, there will be nystagmus, but the magnitude, okay, will get more, or the patient will actually have more dizziness, when when one of the eye is covered. And then the fourth one is congenital nystagmus, people born with it. Okay, people born with this nystagmus, and acquired nystagmus is they have it, as I mentioned, when they have tumor, diabetic retinopathy, or any head injury that happens later in life. That's the time that patient will have this nystagmus. Otherwise, they wouldn't have this. Okay. Next one is classification of this nystagmus based on the type of motions that they make. Okay, so there are two classification. One is a pendular nystagmus. Okay, another one is jerk nystagmus. Okay, first I show you the video of this. This is pendular nystagmus. You see how, if you still remember your science lab, right, you learn on how this pendular movement happens like this. Okay, so the speed of movement of the eyes is in the same in both directions. Okay, so it moves like a, in the pendular movement. And then the second one is the jerk. This is the jerk nystagmus. Okay, the eyes move slowly in one direction and then quickly jerk back in the other direction. So that's a jerking movement. Okay, so these are the two types of, or two classification of the nystagmus based on the motion of the eyes. Okay, the previous one is based on the symptoms that the patient has. Okay, it is the most commonly caused by a neurological problem that is present at birth or develops in childhood or early childhood, or in acquired case, it's any time in the life. Okay, so it can be other causes of include control in early life. Okay, albinism, as I mentioned. Okay, very high refractive error. Okay, albinism is when the patient is not having pigments in the eye. Okay, so everything is white, the skin, the hair, everything is white, and they don't have pigments in the eye. Okay, in the iris will be white. They don't have RPE layers because they don't have pigment. Okay, all these are without pigments. So when there is no pigmentation, what will happen to this patient is, okay, when the light goes in, there is no absorption of light happens at the iris, okay, or in the retinal layers. So all the lights that patients go to eye, too much of light cause scattering of light inside the eye. So that will lead them to have, a glare problem. And at the same time, because the fovea is not developed, okay, because of this, they are day one after they born. So eye be will find the cells zone so that, the light can be absorbed. So they will have that. Okay, next is very high refractive error. For example, myopia or astigmatism, as I mentioned earlier also, similar. Congenital cataracts, okay, development problem also. Inflammation of the inner ear that is connected to the ear also can lead to this. Medications such as anti-epilepsy drugs, for depression tablets, that kind also can lead this because of the relaxation factors in the drugs, which lead them to not have control in the movement of the eye. Central nervous system diseases also can lead this. So what are the management that is available for nystagmus? Obviously, the first one is optical method, glasses, contact lenses, over minus lenses, prism lenses, okay? Anything to, correct the refractive error, and also, any specialized lens to help them to see better. Next one is medications like, Botox injection to control the movement of the eye, drugs, and also surgical management to control the movement of the eye. But what we do in the low vision clinic, okay? So what we do in the low vision clinic is null zone training. There is a training for this. It's very simple, okay? A very simple thing. Okay, first of all, we have to find out what is the null point in the nystagmus patient. So basically, just do a ocular motility test and see at which gaze the patient is having the least magnitude of nystagmus. Is it at the top gaze? Is it at bottom? Is it right? Or is it anywhere? Okay. If let's say the least magnitude of the nystagmus at the primary gaze, that thing can be done. Okay. But if let's say there is a at one gaze that the patient is actually having the least movement. Okay, for example, when, if let's say I'm the patient, when I turn my gaze to the right side and I have minimal or no nystagmus at all. So what you as an clinician have to do is you have to ask them to turn their head to the opposite direction. That means if let's say I'm looking at here, I can have the least magnitude of nystagmus. So I have to turn my head to the opposite side, okay? So that, I can have like a head tilt like this, so that my nystagmus will be in the lowest magnitude. So what is the benefit having this head tilt? Okay, so you have to train the patient. Okay, first you show them that when they turn their head to the opposite side, they have like a just now, like, the world feel like shaking, dizziness, and all that. So when they turn their head, ask them whether that actually improves or not. If let's say it improves, then this we can actually go for the null zone training. Okay, so we train the patient to use this head turn. Okay, one is to reduce the symptoms. Number two, we expect the visual acuity is slightly better at this area. So somehow during the development of the fovea, this particular area has actually a few percentage of the specialized lenses, which are specialized cell development in this area that make the patient to have a slightly better VA. Okay, so that is the reason why we want to train patient with the null zone training. Okay, that means first the symptoms is lesser, and we expect the visual acuity is also to be higher for this patient. Okay, so if let's say that is already confirmed, then you discuss with the patient. Okay, explain this. Okay, so we actually, we want to train you to use, your eye in a different position, because we find that at that particular gaze, your your vision is actually, it's so much better. And also your symptoms is lesser when you have that particular, when you use that particular gaze. So for that, we would like to actually train you to turn your head to this side, okay, and then try to utilize your vision with the head turn, okay. But as I mentioned earlier, we have to always tell them the drawback points or the disadvantage of this also. So the disadvantage would be the excuse me, cosmetic, appearance will not be good, because whenever they're talking to someone or they're doing anything, yes, there will be eye contact, but the head will be turned to one side. So they will have this head turn. Okay, once it becomes a habit, this head turn will be all the time in, to the one side, because once they can see clearly, right, they always go for that particular gaze. Okay, so that need to be explained to the patient. If let's say the patient agrees, then you start off with this. First, you start with the distance vision first, similar to the eccentric viewing training. But that one is when patients say the smiley is clearest on the right hand side, the eye has to turn to the left hand side. Null zone training, if let's say the right hand side gaze is showing least magnitude of nystagmus, the head has to turn to the opposite side. Okay, so that's the difference between eccentric viewing training and also the nystagmus, and train them with null zone training. Okay, so once already explained and all that and patient agree to it, then we start off with the distance vision first. Okay, just ask them to go back, okay, and try to use these words at home. Okay, whenever they go out, if let's say they go to office and all that, try to use this. And also whenever they go to unfamiliar places, ask them to use this null zone point and see whether it actually make them to see better, more comfortable, more confident in doing the activity or not. Okay, so just give them like a 2 to 3 weeks, let them try, and then come back. If let's say after they come back, they say that no, it's not good. Yes, I can see better, but this cost me, some neck problem, or I'm not comfortable with it. Then we can see how we can actually, refer them to physio, and write a report saying that they have to have this hidden, but they have this kind of issue. What we can work together with the physio, okay, to make the vision in a uh, um, you know we can help them with this null zone training. We can also discuss with them. Okay, so if let's say the patient comes back after 2 to 3 weeks and they find it that it is actually very helpful and they like it so much, then we actually ask them, we train them with the near one also. If let's say they have to do reading, they have to check phones and all that, try to use this null zone point. Okay, so try to use a have the head turn and see whether that actually make them feel comfortable or not. Writing, reading, any near craft work, anything that is related to near, they can actually utilize this and see whether it works good or not. If let's say it works, in the clinic, then ask them to go back and try with their daily activities at home. And then come back, give feedback, and then we will discuss on how to improvise this based on the feedback that patient gives after trying it for 2 to 3 weeks. Usually, if let's say there is an improvement in VA at that particular gaze, okay, patient would definitely go for the head turn, okay, because they could see better. Okay, nystagmus is lesser, so definitely they will be very comfortable using that particular areas to actually to have the hidden for all the activities that they do. Okay, so that's all for the nystagmus. Thank you so much. I'll see you again in another video. So today we covered on nystagmus. We looked at what are the types of nystagmus, what are the how do we classify the nystagmus based on the type of movement the patient is having, and what are the causes of this nystagmus. And also we looked at how to manage this nystagmus with the null zone training, and we also looked at the procedure of doing the test. Okay, first, um, need to do a motility test. So based on the motility test, then we do the training, looking at the by looking at the least magnitude of nystagmus gaze, and based on that, we train them to use the head turn. We start off with distance, and then we go for the near one. Okay, that's all for the video. Thank you. We'll see you with another video.